Hi, I'm Dr. Lucky Seacon. I'm a fertility doctor. I actually just got done with doing 6 consecutive embryo transfers for a bunch of my patients. And as I was walking back to my office, I thought of a great idea for a video to talk about the factors or the things that I do to prepare that I think can ensure the most successful outcome possible. I think one of the biggest factors is making sure you image the uterine cavity prior to the transfer cycle prep. There are many different ways to go about doing this, and so I want to run through 3 major imaging options that I like to do in the lead up to the transfer. And the lead up doesn't have to be the cycle before, but I like to do fairly recent imaging, usually within 6 months of a transfer cycle. I think within a year could be appropriate, but you always want to make sure you're getting updated imaging to rule out things like polyps, fibroids, scar tissue, a septum, things that may not be immediately apparent when you're just doing a standard ultrasound, because the uterine cavity is a collapsed space, and only by filling it with fluid or contrast are you able to actually see the outline or the contour of the uterine cavity. So here are a few examples of ways that you can image the uterine cavity prior to a transfer cycle. One option for imaging is a hysterosalpingogram or an HSG. This is where you go to a radiology office, or maybe your REI can do this. It involves an X-ray of the pelvis after putting dye that lights up on the X-ray into the cervical canal and watching it spill and fill the entire uterine cavity and go through the fallopian tubes. And it allows you to assess whether the tubes are open and to show a contour of the uterus. It's actually just a silhouette, so you might lose some detail, and it's not the most sensitive way to detect things like polyps or small structural defects that are jutting into the cavity, but it can give you a pretty good view. Another downside of doing an HSG is it does tend to be really crampy and painful when you compare it to some of the other options. Another option is something called a saline sonogram, a saline infusion sonogram, or an SIS, where you get a side view on ultrasound of the uterus, and you can see the lining here. And then you actually use a catheter to fill the uterine cavity with fluid, saline, and you push the walls apart and you can get a really nice clear view. This is a very accurate, sensitive way to pick up things like polyps, fibroids, scar tissue, even a septum. I tend to do this in most of my patients in the months leading up to a transfer cycle. One of the downsides of doing a saline sonogram is that you're not getting any information about the fallopian tubes, and that could be relevant, especially in patients who've had multiple miscarriages or embryos aren't implanting. Sometimes it is beneficial to evaluate the fallopian tubes to make sure there isn't something going on there. The third option is something called a hysteroscopy. This can be done in the office, but usually it's done in an operating room setting and with some form of sedation or anesthesia. So the patient is calm and not moving around. And basically it involves going through the cervix with a long thin camera, and this is the view you get of looking at the uterine cavity under direct visualization, and you can see the fallopian tube entry point at both sides. Those are called the tubal ostia. And the nice thing about doing a hysteroscopy is it's direct visualizations. You're really not going to miss any pathology if there is any problems in the uterine cavity, and you can also treat it at that time. So if you see a polyp, you can remove the polyp. And so it saves the patient a potential second step. You can also do biopsies under guidance of the hysteroscope. So this is a great option, but it is a little bit more involved if you're doing it in an operating room setting. It is viewed as being more invasive if you're actually doing something in terms of a procedure, but it's probably the most accurate way to assess the uterine cavity. And this is definitely something that I opt to do in patients who've had failed transfers or patients who've had recurrent losses, or if we note that there are abnormalities on a saline sonogram or on an HSG, then the next step is to do this hysteroscopy.